Hello, everyone, and thank you for joining today. My name is Chris Jaden, and I support communications for Quill.com. And I'm pleased to be your host today, as well as your moderator for today's webinar. So to give you some quick background before we get started, Quill has been looking for ways to really help customers like all of you tuning in to navigate this difficult environment outside of just trying to sell you products. So we know that it's vital right now to be considering how to effectively reopen, and that it's a very difficult process to do so. So we're hoping that we can play even just a small part in helping you. And if we can do that, we really aim to do just that today. So today, our discussion is truly just for you and your benefit, and you're not going to hear any product pitches, anything like that. We have some great content. We have a subject matter expert on the line who I'll be throwing it to in just a moment. And we're going to leave time at the very end to dig into a lot of the questions that we've actually gotten submitted before the webinar from all of you tuning in. But before we get into the content on that topic of questions, I just want to mention that even though we'll do questions at the end, you can actually send questions throughout the presentation our way so that we can have those sort of queued up. So when we get to the open question portion of the webinar, we'll have yours ready to go. So to do that, very simple. Simply click on the live event Q&A, which is located on the right-hand side panel of the screen that you're viewing the webinar through. So you can go in there, you can submit a question our way, and then we'll do our best to get that in queue. One other just quick housekeeping item I'll mention is don't fret if you get disconnected. We're going to be recording today's webinar, and we're going to be distributing the recording and the materials, etc. out afterwards. So we'll make sure that you have everything. With that, I want to introduce our speaker today, Dr. Shannon Magari, who is going to speak with you about the topic of keeping your workplace safe during COVID-19. So some quick background on Dr. Magari here. So Dr. Magari holds a doctorate of science in environmental health from Harvard University with a concentration in occupational epidemiology and a master's degree in public health and engineering. As a principal owner of Colden, Dr. Magari serves as the Vice President of Health Sciences and co-chair of the litigation support practice. She continues to perform air quality research through an academic appointment at the T.H. Chan Harvard School of Public Health and currently serves as the President of the Northeast Biological Safety Association. So a wonderful speaker we have on the line here for you today. And with that, it's my pleasure to turn it over to Dr. Magari. Dr. Magari, it's all yours.
Chris, thank you for the introduction and certainly for the opportunity to speak with your customers. It's really important to me as a public health practitioner that we get the message out about how to stay healthy and safe, how to keep our friends and colleagues and families healthy and safe. This webinar is focused on the workplace, but there are a lot of principles that we can take home with us to keep our family and friends safe as well. At this time, most folks are actually contracting the virus in family settings and household groups outside of the workplace. So we want to take these principles home as well. So, just to keep it a little light here, I am a scientist. I've worked in obscurity most of my life. And it's just baffling to me that 6 months ago, 97% of the planet couldn't tell you what an epidemiologist was or did. And now I seem to be pretty popular. So it's pretty funny. I don't think I'm ever going to have to tell anyone what an epidemiologist is anymore. So we'll jump right into it. Next slide, Lisa. And I want to just do a little high overview here for 1 minute, make sure that I think we're all on the same page. This was a great graphic that the New York Times put together eons ago, it seems, in March, just to make sure that everyone knows on the line that, coronaviruses are not new. We've had them forever and ever and ever. And I would bet most everyone on the line has had a coronavirus infection before in the past. It's responsible for the common cold and some more serious, pneumonia. Looking back into not that long ago, in 2003, we had SARS-CoV-2. In 2012, we had and still have outbreaks of MERS, or the Middle Eastern Respiratory Syndrome, which is another coronavirus. And now the 2019 novel coronavirus, or rebranded SARS-CoV-2 just a few months ago, which again seems like long ago. These things are going to keep happening, where people are in places and doing things where nature hits animals, and that's where we get these things. They're called zoonotic illnesses that jump over. The good news here is that it's actually not that hardy of a virus. The coronavirus has this lipid, oily layer all the way around the outside, and we can take advantage of that and destroy that lipid layer with soap and water, which is why washing our hands is so absolutely critical at this time. Next slide. So I just want to start with a little bit of history. And I just want everyone to know we are not defenseless. We absolutely can have an influence on the time course of this virus, absolutely. And we know this for a number of reasons. And we know it because not in that distant of a past, just 100 years ago, we had the 1918 flu, or the Spanish flu as it's sometimes called. And history is very powerful if we're paying attention. This is a great graphic that National Geographic put together just a little while ago about the flu and what happened in 4 major cities in their response. And you can see that Philadelphia has a very quick, very large spike. They didn't shut down really at all until the rise of their illness about 8 days later. They had the highest deaths per 100,000 during that pandemic in the first wave. San Francisco, New York, and St. Louis imparted some measures to control the virus and control the spread. St. Louis had the strongest social distancing and measures and shut down the quickest and the strongest. And they had less than half of the deaths per 100,000 than Philadelphia did. So this is all a very long way of telling you that we absolutely have control over this virus. We are not defenseless. We know what to do. Okay, we just got to figure out what specifically is going to work in our areas, in our homes, in our businesses, to keep people away from each other a little bit and contain the virus. So I'm hoping this is an encouraging message that we have control. Next slide. So when we think about infectious diseases, we think about the basic reproduction number, or called R0, okay, which maybe you've heard of, maybe you haven't. We absolutely have control over this, okay? That's the R0 is essentially how many people does one sick person infect, okay? And we want to drive it below 1, okay? We want to drive it to 0. The only thing that will drive it to 0 anytime quickly is going to be a vaccine. But our behaviors and the things that we can do can help us drive it to less than 1. And just for a benchmark, we know the 1918 flu, depending on areas, had an R0 of 1.4 to 2.8. So one person was infecting about 1.4 to 2.8 people. Contrast that with measles, which is crazy infectious, which is why everyone should be vaccinated. One person with measles can infect up to 18 other people just like that in the time course of their illness. So we know that SARS-CoV-1, we could drive it down to 0.4. In certain outbreak areas, it was up to 3.5. Right now, based on our contact tracing, it's looking like SARS-CoV-2 is about 1.5 to up to 5, which is too high, which is absolutely too high. We're not gonna get a handle on it. I know some people are thinking about herd immunity. It's just not an option. It's actually barely an option for even measles. You've got to have 80, 85, 90% of your population immune, okay, by vaccine or prior infection, before the measly 10% left are going to be protected. So it really isn't an option. On the way to even getting close to that, a lot of people are going to die unnecessarily. So we shouldn't be thinking about, those old-fashioned chickenpox parties or whatnot. It's just absolutely not going to have an impact. So next slide. So, here's just a quick little graphic of even just an R naught of 2. So one person infecting 2 people and them infecting 2 more. So 1 makes 2, makes 4, makes 8, makes 16. I mean, this is just, you can see how this can grow crazy fast. Next slide. So I want to start with the basics. There are 3 ways in which you can contract this virus, okay? 2 of them are kind of the same thing, but I'm gonna split a hair for you because I think it's important. So the main way in which people contract this virus is large droplet transmission, person to person, close contact, probably within 6 feet, although 6 feet isn't a magic number. We'll talk about that. So it's large droplets, okay? A second, smaller portion, we're not sure what, smallish, still something we can control, are the micronuclei. So when you talk or exhale or cough or sneeze, you emit a range of particle sizes, okay, from large, 100 microns, things you can see, down to small micronuclei, 5 microns, okay, that are going to remain airborne. They have no mass, so they don't settle out. The only way you get rid of them is by turning air over in a room, or they dry out, they desiccate and go away, okay? Smaller portion, for sure. The last way in which we know you can get it, again, a smaller portion, based on MERS and SARS-CoV-1, maybe 10% of the transmission, maybe 15% of the transmission, much less, is dirty hands to eyes, nose, and mouth contact, which is why I want to keep surfaces clean, okay? So again, 3 ways: large droplet transmission, micronuclei, and dirty surface to hands, eyes, nose, and mouth, okay? Next slide. Again, we have control over all of these things, okay? So maybe some of you have seen this, but this absolutely is the rubric that we as health and safety professionals use to keep people healthy and safe at work. Full stop. This applies no matter what workplace I'm going into. I'm also a biosafety professional. I do a lot of work in laboratory spaces, in higher ed and research, in food and pharma. This is the rubric that applies. It applies in an office setting where we've never really had to think so much about health and safety or cleaning or any of these things, really. It's universal. It helps protect employees from chemical, physical, and biological hazards. Just so happens right now, we're thinking about a biological hazard. Last week, we were thinking about noise and ergonomics and maybe lead in a production setting or whatever, heavy metal we were thinking of. The past few months, we've been thinking about biological hazards. And I just want to walk you through these layers of defense. Okay, in every single slice, there are things we absolutely can do to help keep people healthy and safe at work. The only magic bullet that we have here available to us is a vaccine. Okay, we're not going to have that for a while, so we need to layer on protection in each one of these slices. And so I'm going to go through each slice, what it means for your workplace, whether you've got 5 people in the office, 50, 100, 5,000. It may mean something a little different for you, but I'm going to talk pretty high level so that as you're making notes and pulling your COVID-19 plans together, health and safety plans, you can brainstorm what this slice means for you. Next slide, Melissa. So always, the best thing you can do to mitigate risk from a hazard is eliminate it. Just get rid of it. If it doesn't exist, it can't harm anyone. If you can't eliminate, you want to make a less hazardous substitution, okay? So elimination for this virus largely consists of, right now, again, without a vaccination, which would be the perfect elimination, removing sick people from the workplace. Okay, sick people just cannot come to work anymore. This whole, I'm a little bit of a germaphobe. This whole, I'm going to work through the illness, I'm going to go to work sick, no, it just cannot happen anymore. People have got to take time to go home and get better. The consequences are just too high now, okay? So removing sick people from the workplace and screening them out, okay? And what does screening look like? So the CDC has got some good screening guidelines, should be pretty quick. In the mornings, it's a temperature check, and you can do that a number of ways. Have people just check at home before they even come into the office. Might be most efficient, depending on your work population. That may or may not be the best way to do it. And then a set of questions. You know, do you have the symptoms of COVID-19? Do you live with or take care of someone who has been diagnosed or has the symptoms? Essentially, are the large questions. The travel questions are coming back again. Again, this is all outlined on the CDC website for screening. International travel, for sure, they're recommending people quarantine when they get back. And some states, you got to really check the state that you're in. If there's work travel, whether you can go to any given state, and then what happens when you come back, you may be required to quarantine. But those screening questions are absolutely critical. I know I had some, and again, thank you to everyone who submitted questions ahead of time. I had some questions about, geez, are these temperature checks really working? And the answer is, yeah, they are. So we've got some large campus sites. Again, not everyone develops a fever. Some people remain completely asymptomatic. But for every sick person, you know, with the concept that there's a whole bunch of other undetected illness, when we know that there are a large portion of asymptomatic carriers. So even if you're catching, you know, one person a week to a month, it absolutely was worth it. And again, it can be done quickly at home in the smaller group office settings and smaller clients that we have. That seems to be very effective, sort of testifying that you don't have a fever or the answering no to all the screening questions before you come in. Substitution is hard, and these are very touchy issues. We might want to think differently about our vulnerable populations and what kinds of restrictions might we have to maybe bring them back to the workplace last. And the CDC, again, has a great list of vulnerable populations, you know, some of our older folks, people with diabetes, heart conditions, immunosuppressed folks, thinking about substituting in a healthier population first before we look to those folks. Absolutely, you need to take HR advice. That's a scientist talking. That's not a legal practitioner. The hope, and we don't know yet. We've got some early evidence, which is not fabulous. Hopefully, we'll know someday what the antibodies mean. Hopefully, we'll understand if having had it means something. Does it mean that you're immune? Or early data says that the antibodies come and go. If you've got a good case of it, antibodies come and go within a couple months. So maybe you're not immune. Maybe you can get it again. There are some asymptomatic infected and some people with mild cases that don't develop antibodies at all. So I don't know. I'm crossing my fingers that the antibodies will mean something someday. Right now, they don't mean a whole bunch. It's an exposure marker. Yes, you've had it. You know, tick the mark or not. So, so that's elimination and substitution. Next slide, Melissa. If we can't eliminate, we can't substitute, we want to engineer out the hazard. Okay, and these are things that isolate people from the hazard. People don't actually need to participate in them for them to be effective, which is great because people are doing their jobs. They're not necessarily thinking about health and safety all the time. Okay, and so as much as we can do for them without them having to participate in, that'd be great. Right now, we're thinking a lot about HVAC and harnessing the power that our ventilation systems can give us and helping to mitigate that smaller risk from the micronuclei. The American Society of Heating, Refrigeration, and Air Conditioning Engineers came out very early and very strong in April with some recommendations for the operation of the HVAC systems, which are bulleted right here. More fresh air. And in fact, they said 100% fresh air, which is crazy. If your system can handle that for temperature and humidity, more air changes, just moving more air, and then better filtration up to MERV 13 or 14 if your system can handle the pressure drops. So they really came out strong about making sure people had lots of clean, filtered, fresh air. Okay. I know there are a lot of questions about ultraviolet light, and absolutely we use UVC, and I got another slide on that, in very specific settings. If the system that you have was designed with UV, germicidal UV in it, absolutely should use it and maintain it, whatnot. These things are very expensive to retrofit. At this time for this virus, we're not recommending that folks make those kinds of capital investments. But if you've got it, absolutely, you can harness it, making sure that the system is getting the air dosed properly, for sure. There is a place, and Ashley did recommend some in-room high efficiency particle air filtration units in areas where you can't get fresh air, where you just can't move more air, or the system can't handle pressure drops for better filtration. There are some in-room HEPA units. We spec them out for clients. They tend to be a little loud. A lot of the larger units, 4,000 or 5,000 CFM units, were adapted from hospital isolation settings, and they're kind of loud and clunky. There are some smaller units that we spec'd out for hospitality clients that presumably you could sleep with, so they're not terribly noisy, but you're really looking at speccing out clean air delivery rates on those things. But there's definitely a time and a place for those things. I wouldn't just put them in willy-nilly all over the place. And then, as you've seen, physical barriers. This one's huge. I mean, there's just been a run on plexiglass. I'm not sure you could find it anywhere these days. But installing sneeze guards and physical barriers between people to certainly keep people separated from each other in a high priority space where you can't maintain at least 6 feet, for sure. And then a lot of touchless surfaces, doors, faucets. I don't think a building will be designed post-COVID that doesn't have an automatic door on it, for instance. So thinking about those kinds of things, and whatever setting you've got, whatever vintage building you've got, to just isolate people from the hazard. Melissa, next slide. So if you can't eliminate, substitute, or engineer out, we want to next think about administrative controls. And this is the largest slice of control that we're probably going to have to harness here during COVID. This actually changes the way people work. It actually requires people to participate and think differently about work. And human behavior is a funny thing, right? So things that fall into administrative controls, I think everybody's heard a lot about them, but really brainstorming and involving employees in the process of coming up with a list of administrative controls that are going to work for you is going to be really important. The absolute most important thing right now is hand hygiene, okay? Performing proper, consistent hand hygiene requires people to participate. Hand washing is the cornerstone of public health. Even though dirty hand to eye, nose, and mouth contact is one of the smaller ways in which you can contract the virus, we absolutely want to keep our hands clean, okay? We want to maintain at least 6 feet between people, and 6 feet isn't magic. We've got aerosol studies that tell us in certain settings with airflows and et cetera, that, a sneeze going at 100 miles an hour could go to 12 feet, okay? But again, we want to at least 6 feet. Is the experience we have in the hospitals and infection control studies, okay? And then all the other things that you see happening, so limiting the number of gathered people, fewer desks, fewer tables in cafeterias just to prevent people from gathering, making sure there's tons of opportunities for hand hygiene with hand sanitizing stations, staggering work shifts. I've got clients who have generated A shifts and B shifts, and A's come in Mondays and Tuesdays, B's come in Thursdays and Fridays, everybody's remote on Wednesdays to clean the office. So whatever that means to you, so that there isn't, in your teams, you've got duplicate skill sets, so that if one team gets sick and has to quarantine, you've got a replicate set of skills over here, those kinds of things. Continuing work from home, for sure, and being creative. You know, I'm in Maine where it's 78 and sunny, and I could have meetings outside if I wanted to. I don't know if that's possible when it's 97 degrees outside and bright sun, or what it's going to mean for this fall. But I'm really encouraging clients to push themselves to think about what can they do outside. Can they put picnic tables outside under a tent for lunch? Can you install a computer outside so people can Zoom meet? The people that are in the office can Zoom meet with people out. Can you have 2-person, 3-person, maybe 4-person meetings at a picnic table outside safely? Can you have a walking meeting? I've got clients who've generated 30-minute routes so that people know how to, you know, what routes take for a 30-minute meeting. So really challenging people to think about outside activities at this time. Melissa, next slide. So we had a ton of questions that came through on cleaning. Okay, and you know, early on, everybody wanted to scrub everything clean because that was something visible and that was something we could do and that was going to protect us. Okay, and I just want to back people away from the edge of how long this virus survives on various surfaces and what kind of cleaning and disinfection is effective. In my world, clean means many different things. So you clean a surface to remove organic debris, okay? You sanitize to reduce microbial loads. You disinfect to kill and further reduce microbial loads. And then at the end of the spectrum, you sterilize to kill things, okay? So in this grand spectrum, we want to clean and disinfect, okay? You can see here, on various surfaces, the virus can last. We have 2 studies now just this year, different viral loads, a little bit different laboratory setups, but you can see, you know, let's say paper, 3 hours. I have a lot of clients that are worried about the mail, you know. The virus can survive at a pretty high initial viral load for up to about 3 hours. And about 7 days at the outset on smooth surfaces, so stainless steel, plastics, and then surgical masks were very interesting. These are the ASTM ear loop masks they did the study on. So, and everything in between, okay, which is why the CDC has said, if an area hasn't been occupied for 7 days with someone that's infected, you're fine. Like, you don't need to do necessarily any additional or extra cleaning or disinfection. So, you know, the other interesting one there, paper was 3 hours, cardboard's 2 days. So I've got clients that were really very concerned early on about the mail, and they instituted policies to just let the mail come in, sit for a day, and they deal with it the following day. Next slide, Melissa. So in the administrative control, so I went through that. So we clean, we sanitize, we disinfect, and we sterilize. That's how we get down to 0 microbial load. It is very hard to disinfect a dirty surface, okay? Some products you can buy will clean and disinfect at the same time, but you've got to break up grease, you've got to get rid of visible debris, you've got to get rid of salts from surfaces, so that you can actually disinfect and start killing some bugs. For sure, we recommend you use EPA N-listed registered agents. So you just type in EPA N-list and it'll search products. There's a little search button. You can put in the products that you've got and make sure that they're listed. And if not, you need to find something that's listed. If you're getting back to absolute basics, a very dilute bleach solution made up fresh every other day approximately will be just fine too, okay? The important thing, I think folks are realizing early on that there's a dwell time. So whatever cleaning agent you've got, you want to make sure you're reading the dwell time. Some of these agents need to be wet, actively wet, for up to 5 or 10 minutes. Okay, you can't spray it and wipe it off, right? You got to spray it and let it be wet so that it can in effect a kill. And some of them are in the 30 seconds or 2-minute range, but you really got to read the instructions. Okay. And as far as cleaning goes, I've got clients that are switching from night cleaning to day cleaning. So there's a visibility issue so that employees are feeling better about getting back to a clean space. Making sure you're reviewing your plans for who should clean, how often, what surfaces. High touch surfaces, we're recommending, at least twice or 3 times a day. And those are all the high touch surfaces. Who should clean? Your regular cleaners, have a good talk with them, make sure you understand what their protocols are. And then quite frankly, for personal spaces and high touch spaces, the copy machine, the microwave, I think it's absolutely legit to ask employees to participate. So leave out sanitizing wipes, which are perfectly safe to use, so that it makes it easy to have employees participate in keeping the workplace clean. Next slide. Other cleaning things that had fallen into the administrative control section. Again, we had a lot of cleaning questions. A lot of pros and cons to germicidal ultraviolet light. So that would be in the UVC range. There's UVA, B, and C is what we're talking about here. There are pros and cons to it. In enclosed settings, like your HVAC system, you can get a high dose very close to a surface with air running fairly slowly to kill microbes. If I've seen some wands that people use and they just wave them around. When you think about ultraviolet light, it kills because it's breaking bonds and disrupting proteins, which means that it could hurt you too. So there's pros and cons to these things. These generally get used in hospital settings. You have to get a dose of UV light, so a time and a distance that's close enough for long enough to actually kill bugs. Anything that's shadowed that doesn't get a dose of light isn't going to get clean. So if you've got something sitting on a surface and you put a UV light on it, anything that doesn't see the light isn't going to get clean. So there's pros and cons to these things. I've seen UV boxes that people buy. Again, if there's any shadowing in there, it's not going to get cleaned. Again, mostly these things are useful in hospital settings where they can use it as an adjuvant to clean a room after a COVID patient exits. Electrostatic spraying is super popular. Again, pros and cons. It lays down a very thin coat of disinfectant, and you got to make sure you get the dwell time. So it can lay down a thin coat, but is it going to stay wet long enough to do its job? Are the surfaces you're spraying compatible with whatever's in it? You wouldn't use it. I know people are starting to use this word fogging. You don't fog the air. You wouldn't use an electrostatic sprayer to do that kind of thing. Electrostatic sprayers are great, and you can put anything in them. I know certain companies sell their product with it, but you can put anything water soluble in it from the N list, from EPA's N list. These things are great, like as an extra. You would never eliminate a good old hand scrub, like in a bathroom or where there's a lot of hard surfaces. It'll kind of like wrap around and kill bacteria in harder to hit places. So there's definitely some pros and cons to electrostatic spraying. We spec it out in, again, bathrooms, locker rooms, some storage areas, break rooms, this kind of thing. So really think long and hard about the electrostatic spraying. Hard surfaces versus soft surfaces, absolutely. Hard surfaces are easier to disinfect. For soft surfaces, carpets, fabrics, a lot of commercial fabrics are actually, in fact, plastic. So you can spray them and wipe them down. EPA on the N list only has 2 or 3 things that are listed for soft surfaces, but in fact, if you read deep into it, it's for washing them in a washing machine. So soft surfaces, you're probably just going to have to rely on time, and I would suggest you eliminate a lot of soft surfaces, throw pillows and any of that kind of stuff, or put covers on things that you can take and wash until the heat of this is over with. And then material compatibilities. Dilute bleach solution is great. It's going to kill a lot of things. It's also going to disrupt a lot of surfaces. It'll pit stainless steel in the long run. So just make sure you're thinking about those things in sustainability. We're not going to be out of this anytime soon. So whatever you're doing has got to be repeatable. Melissa, next slide. And then lastly, we're going to talk about PPE, and this is the part that's hard. It's always our last choice as health and safety professionals. It absolutely requires people to participate. It requires them to participate in something that's probably not going to be that pleasant, okay? I'm going to start with glove use. We want folks to refer back to their original job safety analyses. If, in general, if people weren't wearing gloves pre-COVID, they probably don't need them post-COVID. We've run into a couple of situations, but the focus really should be on hand hygiene. Work uniforms have been fantastic for most situations, healthcare notwithstanding, and CDC again has great laundry guidance on their website. And then really thinking about the need for eye protection. If social distancing cannot be maintained, you don't have a barrier, absolutely face shields or goggles or glasses to get some eye protection. Face shields are absolutely not a substitute for face coverings. Next slide. So here we go. Face coverings. So I had a ton of questions on this. The first bullet, face coverings for everyone. Okay, it's not an opinion, it's not political, it's not nothing. As much as 2 + 2 is 4, everyone should cover their face. It just is. 2 + 2 is 4, and everyone should cover their face by hook or by crook, okay? There are various levels. I have subject matter experts at Colden who all day long, all I think about is respiratory protection, the full gamut, okay? So a couple of things. So we're reserving our N95 respirators, an equivalent for healthcare. Right now, we still have a shortage of those. Face shields are not a replacement for a close-fitting face covering, okay? Non-woven fabrics tend to be better than any kind of woven or knit fabrics, okay? Some non-woven fabrics are a little bit harder to get a hold of, like even the 3-ply spun or bound, non-bound polypropylene masks are great. You can get them, I see them a little bit more. They're just sort of, they look like surgical masks with ear loops on them. They're just not rated for fluid for the ASTM 1, 2, and 3 scheme, but definitely great. All the homemade stuff, great, absolutely better than nothing. If everyone would just cover their face, we'd largely be able to move about with some freedom. The countries that have universal masking policies, 110% are doing better than we're doing right now. So Singapore, Hong Kong, those people are moving around freely, conducting their business with face coverings, okay? So if we could just get face coverings on everyone, and I mean the nose and the mouth, not just the mouth. I didn't say mouth covering, we mean a mouth and a nose covering. We would be in better shape, take my word for it, okay? As you're writing up your policies, whether you're having folks and allowing them to bring in whatever they want, whether you're supplying it, single use, multiple use, whatever it is, as you're pulling together your policies, and just encouraging you to make sure you know where and when they need to wear them, okay? And that's largely when you're in the office and on the move. But it's also important in those policies to outline when people can take a break. I get it. I've had to wear these things all day. I've had to wear PAPRs and N95s and half face air filtering respirators. They are the pits, and people are going to need to take breaks. So really thinking very importantly in equal measures about when and where they need to wear them and when and where they can take a break, okay? So keeping your mind on those things too. Next slide. So I want to talk just briefly about training. You cannot over communicate at this time. The workplace is going to look very, very different. It can't look the same, okay? So whatever position you're in, whether you're critical infrastructure folks and you never stopped working, whether you all been home for a while and you're trying to get back in the summer, or whether you're waiting to get into fall and you got a little more time to plan, you gotta talk to folks. You've gotta solicit feedback for them. Things that are working with 5 people in the office or 50% in the office might not work when you're at 75% capacity. How are you going to include employees in the decision making? Really harnessing all the good elements that we have of our safety management systems to solicit employee feedback in what's going to work for this workplace that may look exceedingly different than it did, February 15th. Next slide. Along with that training, do we need a new language? You know, some of you are in retail, some of you are dealing with the public. How are you going to communicate with your clients and customers? I'm asking leadership, you know, and large companies to come up with some new language, verbal and nonverbal signals. You know, I see somebody without their mask on now in the grocery store, and I'm appalled. I mean, I give them a hairy eyeball. And as human beings, we can't keep doing that. You know, is there some like baseball signals we can give each other in the office that's like, oh, you're a little too close to me, you know, or instead of back, you know, instead of that negativeness, or maybe someone's sitting in their cube, they were working without their mask and that was okay because you've got barriers. They get up to go to the bathroom, they just legit forgot their mask. Like, is there some kind of signal like, oh, you forgot your mask, like, so that we can just be compassionate to get everybody on this page without shaming and so much negativity. How are you going to communicate with clients and customers? How far can a sign go? You know, I think we all are used to seeing those no shirts, no shoes, no service. Like, how about no shirts, no shoes, no mask, no service? You know, and then we've got crazy, dangerous things happening with people feeling, you know, with workplace violence issues and people, you know, really feeling strongly and letting, you know, someone know it. Do employees need scripts? Does management need to give employees cover when a client comes in without a mask? So all these things need to be ferreted out for sure. Next slide. So just thinking about some of the collateral EHS issues for some of my clients that have come up over the last few months, really thinking through how much longer folks are going to be working at home. If you've got anybody still working at home, what are their home ergonomics issues? So no matter where folks are working, you own those soft tissue injuries. And so making sure people's home workstations are set up really well. If you go to the Colden website, colden.com, on our homepage, we've got some low cost and no cost home setup solutions. Heat, stress, and strain. You know, as summer comes on here and everybody's got that added face covering burden, as small as it may seem to some, really thinking about if you got an environment where you were concerned about heat, stress, or strain before, really dusting off those programs and thinking about how are people going to hydrate with the mask on, etc. We got a lot more people working alone for the first time, either because you purposely de-densified a shift or because someone's sick. Those are serious issues. Working at odd hours, and then the stress and mental health issues are just going to continue to build. So just things that I wanted to highlight that that should be absolutely given some thought to. Next slide. And then I added on some quick slides here. I know Chris wants to get to some other questions that may have come in. I just got a couple slides left, but you know, testing strategies. Should you be testing all of your employees? At this time, the CDC has a great rubric of testing priorities, and that's coming up with people who are, first priority obviously are in the hospitals, second priority are people that are symptomatic, and then the third layer right now are asymptomatic close contacts of people that are sick. And then there's going to be another slice in there for people in unusual situations, so critical infrastructure folks and folks living in large high-risk residential settings, nursing homes. We're going to see it in higher ed this fall in the residential settings. So there's a clear rubric about who should get tested and when. You can refer to that. And that's largely setting out testing for the virus itself. Antigen testing should be coming pretty soon. I think that's going to change the face of this. It's more rapid testing. You can put a higher throughput. For the virus testing for PCR, you can do one test every 15 minutes. I mean, it's just not for an hour with one machine. That's just not going to get us out of this problem. So we need more rapid testing, and that might be the antigen. The antibody testing is super rapid, super inexpensive. We're just not sure if it means anything yet. So, you know, c'est la vie. But thinking about testing employees later in the year absolutely could become part of the rubric right now. If you've got symptomatic employees in the smaller businesses, we're sending folks to their personal health care providers. Absolutely, of course. Next slide. And this is just a note. I'm not going to go through this, but you know, as we have a moment to plan for cold and flu season this fall, just really thinking that the signs and symptoms of COVID-19 are in fact slightly different than the flu. The time course is different. The people that are affected different. Thank heavens the kids aren't getting sick right now. That's not true for flu, where the children are a major vector for the flu, general influenza. So really thinking about flu clinics, encouraging, asking, begging employees to get their flu shots this fall. Even in a bad flu year where we guess wrong on the shot, we're still getting 15–20%, which we may need this fall, really, to keep people working. Next slide. What do you do with a positive case? That was another question that came up quite a bit. You got to have a plan. You absolutely have to have a plan. Okay. So when you have a positive case, I'm hoping that you looked at all those layers of protection and had some redundancy in their job function, right? So that you can still business continuity issues. But once you have a positive case and they've got a test, whoever took the test, that healthcare provider will contact the Department of Health. And employers don't need to do that. The Department of Health will contact you. Most of them are completely overwhelmed, maybe days. In the meantime, to help out the Department of Health, you should start identifying the close contacts in the workplace. And the definition of close contact is contact within 6 feet for 15 minutes or more. And it generally means cumulative. It's like, are 3 5-minute interactions the same as 1 15-minute interaction within 6 feet of each other? And the answer is probably yes. Those folks need to sit out for 14 days. If the person had that they were in contact with had a positive result or was diagnosed with COVID-19. There's no way to shorten up this 14 days, unfortunately. It's not like the people that were asked to quarantine on day 3 or 4 can go get a test and come back. If they're asymptomatic, the test isn't, it doesn't have enough positive predictive value to actually ask them come back. So it really is 14 days for those folks. And then when the Department of Health calls you, they'll ask you a bunch more questions and you can let them know what you turned up. And then they'll initiate proper contact tracing to reach out to the people that you asked to stay home from the workplace. Next slide. What if someone gets sick at work? You need a plan. You know, dust off your emergency response plan. And if you didn't have one, you know, Google it. There's a bunch of templates out there and come out quick. Do you have an emergency contact name and number for everybody in the office? Do you have some mechanism to get employees home safely? If they're not that sick, can they just go home? Are they able to drive themselves? Do you have the number for the Uber or the local cab company to help get them home? Okay. Do you need emergency service? Do you have the, do you know where the 911 is coming from and how long it's going to take to get to you folks? Okay. While someone is sick, have you got a place, a conference room that you can designate, whatever, that you can supply up a little bit to keep someone comfortable while they're waiting for emergency service or while they're waiting for their Uber to come pick them up, whatever that is. And then what's going to happen after they leave? Do you have some special protocols to clean, isolate the work area that they were in and get something done? Do you need a special contractor for whatever reason, whether there was vomit involved, whatever, there's more involved cleanup? Do you have a contractor on board? So thinking about all those things ahead of time is going to be really important too. Next slide. Thinking about how sick employees are going to come back. Again, very clear guidance on the CDC's website. There's 2 lanes right now. If somebody had a positive test and they were asymptomatic, they got to wait out 10 days. If somebody had a positive test and they were symptomatic, there's 2 strategies to bring them back: testing and symptom-based. Most people are doing the symptom-based, which is they can come back after their 10 days out from their first symptoms, 3 days fever-free, and other symptoms are improving. But again, great guidance on the CDC website there. Next slide. To open or close is the question. And so we're helping a lot of clients sort out gating criteria. Open, close. Obviously, we're looking for state and local orders, whether they can or can't be open. For sure, you should be paying attention to those. So it's sort of readiness. It's like, is the state or county ready? Is my building ready? Do I have the cleaning supplies? Do I have an emergency plan? Is HR on top of return to work policies? Those kinds of things. So after the state and county are ready, is the building ready? but are the people ready? You know, and I'm still seeing a lot of really scared folks, and it is what it is. And so people are going to be all in stages of their comfortableness to come back to the office. The criteria that are listed here, the White House and CDC gating criteria, largely are the same thing. The CDC is a little more detailed, but really thinking about case counts in the area, percent positivity, but really encouraging you to absolutely look for vetted sources of information, and that's going to come from your state and local departments of health. Okay, there's a lot of crowdsourced stuff out there. COVIDexitstrategy.org is very good, but at the end of the day, we've got to rely on the vetted sources from state and local health departments. Next slide. And I just want to supply you, I know they're going to post this or send this out. So CDC and WHO, the World Health Organization, absolutely have the best, most vetted information. Anything in the public media at this point, I've considered suspect. Some things from the Times or the Post are okay and quite good, but at this point we have to listen to one voice, and that has to be the CDC for this country. The Quill folks found me on backtoworksafely.org. My trade organization, the American Industrial Hygiene Association, has put up guidance documents based on CDC guidance for various settings, hair salons, retail establishments, production facilities. There's nice PDFs for each type of organization, your state and local health departments. My website is Colden.com. There's a link to information about me, but private consultants are, doing, lifting a heavy weight to keep folks safe. So, Chris, I'll turn it back to you to see if there were any questions that I hadn't hit from the 4 pages that came in before the webinar started.
Very good. Yeah, we had quite a few of them. And are you guys hearing an echo on mine? I just want to make sure that it's.
No, I'm good.
Sounds like we're good. Okay. So we do have quite a few questions. I want to remind everybody that if you have a question, you haven't submitted it, you can do so using the Q&A sort of functionality within the webinar. So if you kind of look to your screen there on the right-hand side, you can send a question in. We've gotten a lot. The number one question we've gotten is, are we going to get this material after the webinar? Yes, you will. This will be sent out via email. You'll have the presentation and the recording, so don't fret there. Dr. Magari, the first question I want to throw your way, just to reinforce what you said before, can you just re-emphasize some of those points you made around the 6 feet and 15-minute rule? Like, does it apply even when wearing masks and quarantining? And can you just talk a little bit more about that?
Yeah, a very good question. So the definition of close contact to initiate contact tracing is within 6 feet for 15 minutes or more, and that's irrespective of any PPE or barriers at this time, okay? There are special lanes for, and then those people within 6 feet for 15 minutes, generally cumulative, we think, are asked for a 14-day quarantine. There are certain exceptions to that 14-day quarantine for critical infrastructure workers, and you can find out if you're a critical infrastructure worker pretty easily, or and largely the largest group of them is sort of utility workers, healthcare workers. There's a pretty long list. Those folks that have had close contact can come back to work with special personal protective equipment.
Thank you very much for clarifying. And then I'm going to go into what I think are questions that fall into sort of the workplace and protocol standards first. 2 sort of what if scenarios came in. The first was, hey, what if we have an employee who's got a boyfriend that just got COVID, as an example? Like, should that person stay home? And then a similar question is, if someone went on vacation or a trip that has connection to high exposures of COVID cases, what do we do with folks in that scenario too? Yeah,
Chris, good question. So I'm going to take them separately because they actually are kind of 2 different situations. So the first situation, if you're doing a good screening and you're following the CDC's line of questions, the employee who lived with a boyfriend who was diagnosed positive or had close contact with a boyfriend would be screened out and they'd be asked to quarantine for 14 days. So that person would not be allowed into the workplace. As far as the travel goes, boy, this is heating up quick. Okay, and for my employees who are traveling all over, industrial hygienists at this point are considered critical infrastructure employees, but you really got to pay attention. And there's large HR issues here, whether they were traveling for work and were exposed potentially in a high area, and whether they're coming back to your home state, whether there's quarantine requirements, or whether they were traveling for paid time off. And what are your rules going to be around paying for a 14-day quarantine if your state is requiring that? So those rules are very specific, and I would recommend you look at the state orders heavily for travel in and out. I think international travel is highly restricted right now. Any international travel, I safely can say, is in a bucket of you have to quarantine when you get back. But the state-to-state travel is going to be very difficult. And don't laugh. AAA, God love old school AAA, has a great map for quarantines. So when it's got a map of the states, and then when you hover over a particular state, it'll drop down the state orders, so you can see what quarantines are required on your way in and back to your home state.
A couple other questions around protocol came in, and I'll bucket them, but feel free to answer them separately. Yeah. Around if an employee tests positive, best practices. Do we notify the rest of our staff? Do we notify patients? Like, I'm assuming this is a medical facility. Do we notify patients? What would you recommend? Kind of questions.
Yeah, so you really got to get with your HR and legal folks. There are a lot of privacy issues associated with doing the contact tracing to notify close contacts of a case. Again, casual contact in a retail setting with other clients or whatever, it would not meet the definition of within 6 feet for 15 minutes. And I'm hoping administratively in those settings that you're doing as much as you can to keep people apart, both time and distance, so that if there are notifications that have to happen, there's as few as possible, if that makes sense, that you're administratively just keeping those folks away from each other. But you are not allowed to reveal, at this time, you're not allowed to reveal people's names when you go do the contact tracing. We have some clients that have worked with legal counsel to create forms that say, geez, to facilitate contact tracing, would you mind if we use your name? And they release that. So we've got clients that are doing it that way, so that, because then otherwise there's conspiracy theories, right? Like, oh, nobody contacted me. Was I in close contact? And in the smaller offices, everyone can figure out who the heck it is anyways. But again, work with HR on, making sure you're not violating any privacy laws.
And I think this will probably be another one of those work with your HR team kind of questions, but I'll pose it anyway. Again, from sort of the medical setting, but could apply elsewhere. What if we have a patient seen in our office and then a few days later indicates they tested positive? Should our whole office be tested? I mean, is there a recommendation?
There isn't a recommendation to test asymptomatic people unless you had close prolonged contact, again, within 6 feet for 15 minutes. So if that patient or client had interaction with an employee for more than 15 minutes, less than 6 feet, the recommendation would be for them to quarantine for 14 days.
Gotcha. And I'm going to pose this one as the last question because I think we're almost at time and I do want to close out. Once you get COVID-19 and recover, is there a chance you can get it again? And then when you look at what that could translate to testing, et cetera, like what's the ongoing best practice folks should adhere to? Yeah.
The honest to God answer to that is we don't know yet. We have some very small evidence that it is possible to become reinfected. There were some large naval ships that came in and employees were symptomatic, tested positive, were cleared by the 2 negative test. They were fine. And then a couple weeks later developed symptoms again and tested positive again. That's not encouraging. I don't know how that's going to pan out. I'm not sure.
Gotcha. Well, thank you for chiming in. To those tuning in, a huge thank you for being here with us today. We have reached the conclusion of our presentation. Sorry we didn't get to all the questions, but please know that this presentation and the recording will be distributed via email after, and as a part of that, you'll have the resources that Dr. Magari had walked through. So recommendation would be to consult those for any additional questions you may have. But with that, thank you for tuning in. Have a wonderful rest of your day, and we will catch you soon.
Thanks.